referring to is this image. So if we biopsy tissue within that, or on the edge of this wound bed, we're going to see characteristically this result. So this is hematoxylin and eosin stained tissue. You can see the wound edges here. You can see on the superficial most, or the top portion, you can see the epithelium. And that epithelium kind of stops, and there's no epithelium covering this portion of the wound bed. So in panel B, this is a large gap that's shown between the edges of the wound. In this particular image in C, as we fill in this tissue, if this heals, we're going to start to remodel it. And we first see that this closes over with a thin reepithelialization. So in you and I, this wound would move on to this stage, and underneath it would be granulation tissue. Now, what are some characteristics that tell you this is granulation tissue? Let's say I showed a slide like this on the exam and I asked you what phase it was. Your wound healing response.
Are those dark purple spots formed by cells?
Are these dark purple spots like here and here?
A little more right.
Pass that. A whole lot easier. All right, Skywalker. Use the laser. Whoa, easy, Turbo. All right.
Those.
Okay, so they're kind of like darker pink.
Yeah.
Yeah. So those are not foreign body giant cells, but I can see why you would think they are. Those are areas where you've got collagen deposition attaching. Okay, so that was actually a good point out. If you were going to see foreign body giant cells in an area, you're going to see it in more than one location. Okay, and I would make it more obvious to you than that. So I try not to trick you. But what you're seeing here is you're starting to see some of the collagen being deposited in that sort of darker pink. All of the purple dots that you see are all the macrophages that are in the area. But the reason you know it's granulation tissue is, do you see this structure right here? This structure here, this structure here, this structure here, this structure here, this one here, this one here. What are all of these? Blood vessels. Who said that? Blood vessels. In fact, in this one you can see a red blood cell right in the middle, waving at you. They don't have arms, but they did. Here's another one. Red blood cell right in the middle of the lumen. Here's a stack of red blood cells. So all of this vasculature shows up in granulation tissue because that's the nutritional flow into the wound to try to promote healing. Then slowly over time here, in panel D, we've got reepithelialization continuing. Now you can start to see the distinct architecture of the epidermis. And we're starting to also contract the wound. So we're bringing the edges of the wound together. And you can see there's sort of this puckering taking place right here as we contract the wound in. And as was pointed out, there's more of that pink stuff right here that we started to see early evidence of it about 2 slides ago. Oops, 1 slide ago, right here. In this particular slide, darn it, we actually see more of it showing up. That's all the collagen that's being deposited, which is part of the scarring. That's the fibrosis that you see. And I kind of let the cat out of the bag. Some patients, you get tremendous amount of collagen production in a scarring, and it forms what's called a keloid. And that's what this picture is. So this is a keloid where you've got excess collagen being deposited. And it only affects certain patients, not all patients keloid over. But this is the result grossly that would show up. Excess collagen being deposited, forming this raised scar. And histologically, all the arrows are pointing to extra collagen being deposited in this area that really shouldn't surface, you can see how this is raised up. And those ridges are characteristic of what you're seeing here on these particular ridges of that keloid. So keloiding of scars is not common. It's a little bit more rare, not unusual, but it does happen. And this is what keloiding looks like, and this is the example histologically of what you would see underneath the skin of a keloid wound healing response. Okay, we're shifting gears. Oh, sorry. Questions? Yes.
Does it stay that way?
Primarily, yes.
Because it looks like when you get burned, and they does that too.
So burns are a whole other ballgame. And so the keloids in these patients that form, they might regress slightly, but a lot of times you're still going to see evidence of that keloid. Okay, and in a burn patient, it's a whole other ballgame as far as a wound healing response. But and you'll get remodeling of the scar, and the scarring will soften, but you'll be able to see evidence of that burn for probably the lifetime of the patient. There's another question here.
Is that keloid something that you would have reordered, like you were talking about?
Oh, could you have it modified? Yes, you can. Yes, you can. So a lot of these keloids can modify, but a lot of times they're going to have to give localized pharmaceuticals in order to diminish the collagen that's being produced. Otherwise, it's going to do it all over again. Okay? So don't do it at home.
The keloid, it was, you said it was mostly collagen.
Yes.
So, speaking from like a dissection standpoint, would it bleed if you cut it?
Would it bleed if you
Yeah.
cut it? Because it's mostly collagen?
Yeah.
Well, so it depends on if it's vascularized or not. So just because it's collagen doesn't necessarily mean that there's no blood vessels there. Okay. So in some cases it might bleed, in some cases it wouldn't. Right? Similar, when people have warts on their skin, sometimes they'll take matters in their own hands and they'll remove them. And sometimes they will bleed, sometimes they won't. But the problem with that is it's a virus, and so if it does bleed, it actually spreads with a wart, not with a keloid. Okay, so we're shifting gears, and I want to talk about some therapeutics that have been used or are being used within the wound care space. And some of this is going to get a little bit into my research. And you'll see a little bit more of this on Wednesday night if you come to that evening lecture. We'll go into even more detail on specifics. But this is definitely a future in medicine that many of you are going to be tapping into. I think it's going to become more standardized care, stem cell therapy over time. If you wind the clock back about 100 years, we weren't doing blood transfusion. And now it's like, oh yeah, so-and-so had to get a little bit of blood post-operatively. And it's like, oh, it's no big deal. Because it's no big deal because we have banks of blood that are stored. We have donors. Many of you in this room are donors. And we screen the blood so it's clean. 100 years ago, that sounded like science fiction or heresy or something that you weren't supposed to do. And now it's common practice. Okay, so medicine is advancing. It really is. And I firmly believe that one of the futures is going to be tapping more into stem cell types of therapy for wound healing is where this is going. These are pictures of different stem cells. We have sources of stem cells. This is actually from bone marrow. You can see the stem cell actually squeezing out of the marrow tissue. We have stem cells that circulate in the blood. We have stem cells that are resident in tissues. Most every tissue in the body has some stem population. Now, not every tissue is able to harvest it, and our ability to harvest those stem cells as we get older is diminished. This is a nice graph that kind of compares and contrasts the different types of stem cells that we have access to. Because I want you guys to be knowledgeable about these stem cells. We talked about this really the first day of class in broad brush strokes. We're coming over it more carefully today. So we've got a classification known as embryonic stem cells, which are these two columns. And then we have what we call adult stem cells, which is this far right column. You can see the attributes, limitations, and ethical concerns of all three categories. In the embryonic realm, some of the advantages of whether it's from in vitro fertilization or what we call nuclear transfer, some of the advantages is that they have the ability to really become most embryo starts from a single cell, and every cell in the body is actually created from that. So embryonic stem cell as a source has a tremendous amount of what we call potency, okay, totipotency, meaning it can become just about anything. Some of the limitations for both of these, whether it's a nuclear transfer or whether it's in vitro fertilization, is there's limited availability. Okay, it's not widely available. Now, of course, maybe even more of a big deal are some of the ethical concerns. And the ethical concerns don't necessarily just mean, you know, your religious beliefs. It could just be your humanitarian beliefs within philosophical ethics. Because when you harvest either one of these, you have the destruction of a human blastocyst. And so whether or not you think that's a problem or not, they're just not widely available. It's not like we have excess blastocysts just floating around in the supermarket.
What's nuclear transfer?
So the question is, what's nuclear transfer? Nuclear transfer is a process by which we find a host cell and we transfer genetic information into that host cell. So you would have a donor oocyte, for example, and you would harvest that from a female, and then you could transfer in genetic information that you wanted to be present versus what was in the original oocyte. Okay, so in that situation, you are sort of hijacking the genome of that particular blastocyst. Make sense?
Yeah.
Okay. If we look at the last category of adult-derived stem cells, these two categories of embryonic stem cells became very popular in the scientific literature in the 90s and the early 2000s. And they've sort of come out of vogue because of a lot of the ethical concerns as well as limitations. And you probably have heard some of these stories where there have been publications by prominent laboratories that actually had to apologize and retract their findings because they couldn't get them to be repeatable. So those were all really in the realm of embryonic stem cell therapy because it was such a hot new field. And so this has actually come down quite a bit, and really where a lot of emphasis is being focused is on adult-derived stem cells. So adult-derived stem cells, we make them. You can harvest your own. You could harvest it at a younger age and bank them for a later use. You could harvest them when you needed them. You can get them easily from a lot of different sources. You can get them from circulating blood. You could get them from the bone marrow, which isn't exactly easy, but it's definitely doable. You can get it from fat-derived stem cells. Okay, and this has become a very popular field because in Western society, where most of the money is available to do new types of therapies, a little bit of liposuction fat is easy to come by. And we have no major ethical concerns because you're donating your own cells. Okay, so another way to look at this is embryonic stem cells up top and induced pluripotent stem cells, which we talked about in the very beginning of the class. These are actually sort of a fourth category that wasn't shown on that chart. So in nuclear transfer and iPS cells are two different types. So the induced pluripotent stem cells are normal cells or adult stem cells that are programmed using enzymes or genetic enzymes to behave like embryonic stem cells. So again, not as controversial. So iPS and adult stem cells are really the two categories that most of the future of stem cells is really focusing on. The iPS is kind of the new embryonic stem cell of today, of the 2010s, if you will, or the 20-teens. Now, if we focus specifically on adult-derived stem cells that come from fat, and this is in my lab where most of our stem cell research is focused, it looks like this. The patient goes through a liposuction surgery. You get what's called lithoaspirate. You go through a couple of washes and aspirations where you're pulling off different levels of fluid. ultimately, you go through a collagenase digestion, which breaks down the collagen and helps to liberate stem cells that are trapped within. Then you culture it out, what's called the stromal vascular fraction, and you specifically target the adipose stem cells, and they can differentiate not into everything or anything. They have limitations, but we've been seeing that they become fat, which is pretty obvious, or you can push them to become bone, muscle, or cartilage. And you can also, now we have a new line here, which is skin. So the way that we've used this technology is in a study that was done by a grad student in my lab, and he's now in medical school, but it involves the use of electrospinning. And electrospinning is a way that we take extracellular matrix proteins that are commonly found in the body, for example in the skin, and we subject them to a charge. So we put them through a soluble syringe pump into a tubing with a needle connected to a positive electrode. This is a high voltage supply. We set this at about 30,000 volts. This is the negative target, and it creates what's called a Taylor cone. It almost looks like spinning spider webs. This is the setup in the lab from that cartoon drawing, and let's see if this plays. And this is the fibers being electrospun onto a resulting target. What we're trying to do is we're trying to first create the extracellular matrix, and then we're going to populate it with cells, skin cells, okay? Or in this case, stem cells that are going to become skin. Okay? So the electrospinning, what it results in are architectures that look like this. So we've got a meshwork, and this is sort of the extracellular matrix that the cells are going to grow and attach to and hang on to. And this is very similar to the type of matrix that's found in your and my skin, architecturally. And you can see that we can turn up at different levels. On the left, we set it at a fast flow rate. On the right, we set it at a slow flow rate, so we can get different levels of porosity. Then we can seed or grow stem cells from fat that we've isolated from lipoaspirate. This is a dividing adipose-derived stem cell here. This is sort of a stem cell underneath what looks like a blanket. It's like Saturday morning in my house where the kids are all hiding in their beds, right? And so this looks like a cell with a blanket of extracellular matrix underneath, over top of the cell. So it's kind of like there's a bump. And then here is the edge, right here, the edge of the matrix has been laid down. And this is the bare scaffold underneath. Okay, so these are the materials that we're using. And this was a study that was done by this grad student where we created a wound model and a preclinical model, full thickness wound where we cut all the way through all layers of the skin, and we implanted this replacement skin, if you will. It had stem cells. We used a immunodeficient mouse because we were using human stem cells, so we didn't want a rejection. We didn't want a xenogenetic rejection. So there's a special type of mouse called a severe combined immunodeficient mouse, and we were implanting human stem cells into its skin. So the model looks something like this, where we create these full thickness wounds using a biopsy dye. And then we created these scaffolds. We grew them in an incubator for about 2 to 3 days max. This is a picture of Hans doing the surgery here on the left. And these are the results. So here's our control wounds. Now keep in mind, this is after 6 days, and control wounds weren't just like left uncovered and like, we spitted them and rubbed our finger on them. We actually use standard of care, which is actually antibiotic ointment, and then you cover it with a Vaseline gauze and then a piece of Tegaderm over top. And that keeps the water from leaving, it keeps the bacteria from getting in. Okay, so that's what's actually resulting in this type of healing response after 6 days. And then on our we looked at 2 different types of scaffolds, an elastin and a collagen, and then we added our human stem cells, and we had almost 100%, and in some cases 100% healing after day 6. So quantitatively, it looks something like this, and we ran statistics. We saw closure, but we saw accelerated closure with our stem cell group. And then if we looked at epithelial thickness, how much of the new epithelium was regenerated, which is an indication that you're getting regeneration and not just scarring, we really saw that we had much greater epithelialization that took place with our stem cell groups than we had with just control healing. The conclusion of that study was that the stem cell therapy works. We could implant in an animal model that didn't have an immune system, so we could test human stem cells that were coming from liposuction fat. And we were early in our days of toying with scaffolds and the architecture of the scaffold. Now, not part of this class, on Wednesday, I'm going to talk more about the next study that took place, because we've actually moved on in our development of more biomimicry, making the scaffolds look more like skin architecture. And I'm going to show those results on Wednesday night. Okay, but I just wanted to give you a snapshot of like what we're doing in our lab. Many others are doing throughout the world. And they're doing not just with skin wound healing, but with liver, with heart, with neural tissue. Okay? It's happening all over the world, these types of studies. We just happen to focus pretty heavily on skin. So I really believe that you're going to be experiencing and being able to use these type of therapies in the future if you go into medicine. Now, there was a question up front.
I was just curious as to how you measured the percentage of healings.
The question is, how did we measure the percent healing? So what we do is we do it quantitatively by taking the area of the wound at the day of creation. And then at day 6, we take the area of the wound, and it's basically a calculation between percent area. Make sense? And then with thickness, to answer, wasn't part of your question, but the other part of the question is, how do you measure epithelial thickness? We do histology, and then we can actually quantitatively measure how thick the epithelium is in all of these samples. Other questions? Okay. So going back to the phases of wound healing, just to kind of wrap things up, and then I'm going to talk about some early technology. This is technology that's brand new, stuff that we're working on right now. And I'm going to give an update on Wednesday night in Klein Library, if you want to hear that. I'm going to talk a little bit more about how this fits into the different phases of wound healing. And I'm going to talk about some really early cutting-edge work that took place by a company that I used to work for that's still on the market today. And we were back then, this is in the late 80s, kind of the pioneers of this wound healing arena of trying to regenerate, not repair, but regenerate tissues. But before we go there, we kind of need to set the stage for the different phases of wound healing. So we've got sort of our inflammatory phase, our proliferation phase, and then our maturation phase. Or you can see the other ways that it's referenced is coagulation or inflammation, migration or proliferation, remodeling or maturation. So what we understand about these phases is in the inflammation phase, there's a breaching of the epidermis where the vessel's damaged, and that leads to the need for blood to flow in, forming this clot. Okay? You've got vascular elements here that are giving rise to the blood flow, as well as the ability for the circulating white blood cells to get out into the tissue. We've been studying that quite aggressively over the last few lectures. Then we have our migration or proliferation phase, where we've got our tissue macrophages in the damaged tissue, and the fibroblasts have gone in and they're proliferating and laying down new collagen. And then as it remodels, or matures, after a period of time, you can appreciate this underlying scar that's present. So these are similar pictures from what we've seen before, just from a different author. So what the result is, and this is a little graphic, so I'm just kind of giving you a heads up. The result is we end up with lesions that look like this, clinically. Right? And the best ability for us to treat this is to approximate this. And we might come in first to debride the wound, clean it out, and then we might freshly cut the edge and try to freshly cut this edge so that when we bring this together, we get really nice approximation. And that's really the best situation that we can have. But what happens, this is an even worse graphic picture, it may not be as bad on your little printouts, it's more pronounced on the big screen, okay? Is what if you can't approximate the wound borders, okay? So this is the burn situation you asked about earlier. There is no approximation that's going to be available in this situation. And so now we get into this whole realm of creating new skin. And that's what we're trying to do now. But where this really began, because currently the standard of care for this type of situation is to try to do grafting. So we can graft from another location of the patient, but in all honesty, if they're this bad, we may not have a lot of sources we can pull tissue from. So then you might move to a cadaver graft. Okay? There are products on the market from pigs or cows, porcine or bovine tissue that's been processed. It's clean, it's sterile, there's no pig cells or cow cells in them. And we use those as patches. But they result in big scars. So in the early days, in like the late 1980s, when I first started doing this work, I was working for a company that was trying to revolutionize the ability for therapeutic options for these patients that don't have good options. Because if the approximation of the wound is not an option, what else are you going to do? You got autologous skin grafting. But in some of those patients, you can't do that. There isn't available skin. So then you go to cadavers or what we call xenografts. Xeno meaning from a different species. That's the pig and the cow. The third category, which is where we're trying to develop new therapies with the stem cell therapy I just talked about, this category of commercial dermal substitutes really began in the late 80s. And so I can't take full credit for what we're doing now because it was set in motion in the late 80s. And this was the company that I was working for at the time called Advanced Tissue Sciences. And the technology that I'm really focusing on is this dermagraft. The concept looks like this. The concept was a bioabsorbable scaffold, and we would manufacture that scaffold in a certain pattern, and then we would transplant fibroblasts from donor patients. We would get the fibroblasts from these donor patients from throwaway foreskin from circumcisions. Interesting source, right? But they're young fibroblasts, and nobody wants it anymore. Okay? So that's where we were clever. The company was very clever to find throwaway young skin, and that's what we did. So we would grow those on this scaffold, very similar to the stem cells. Okay, but now we go around chasing people's fat instead of chasing people's throwaway foreskin. And it sounded really funny. Sounded really bad, actually. But I was going to say something else that was totally inappropriate. So that's not terrible. Well, now we don't have to just chase around little boys. We can chase around men and women. Right? We just need fat. Okay. So after a period of time, the matrix grows, right? The fibroblasts lay down this new matrix, and we have a complete new human tissue. That human tissue looks something like this. This is like a classic picture from like 1989, okay? Michael Jackson was probably playing in the background when we were taking this picture. And this is the polylactic acid fibers, and this is a fibroblast, a dermal fibroblast, a skin fibroblast that's been, see how, remember I was telling you how they grow and they grab on? See how it's grabbing on and attaching? here's a neighboring fibroblast that's off the screen, and here's its attachment. So they literally grow and grab onto the scaffold architecture, and this is a synthetically derived scaffold. So this clinical trial that we did, this is in the mid-90s, so you can see the date on here is right before Thanksgiving. So this is 11, so it started earlier. This is October 17th. Okay, so in the fall of 95, and then we followed it for 10 weeks. This is just after Christmas, December 27th of 1995. And the indication for this technology was for diabetic foot ulcers. And this is where we're going with our stem cell therapy, but we're trying to revolutionize it without using fibroblasts now. We're just using patients' own cells. So this patient comes in, presents at week 0 with, this is the bottom of their heel. This is a dermal foot ulcer, right? So this is the bottom of their heel. How do you think that? I mean, you'd be walking like this all day, huh? Because this sat here, in order to get into the trial, they had to have a non-healing foot ulcer that persisted for at least 6 months. Yeah, that was 6 months old when we saw it. You can appreciate there's a little bit of necrosis all around the edges. Can you tell? So after 10 weeks of therapy, we actually got this thing to close, which had been open for at least 6 months. And we were really excited about this. And the technology is really focused around the following, and that's blood flow. So the idea is, if this is in a patient, and this is the wound, this black area, I don't know if you can appreciate this red tracing. There's a red tracing here. And we were using laser Doppler. So what we did is we would put a probe. It's painless. It's almost like an ultrasound. You just put a little probe over the top of the skin, and you can measure blood flow. And it outputs areas that are light colored, like blue and black, or the light blue, are going to be areas of low blood flow. And the brighter colors, like the reds and the yellows, are indicative of high blood flow. So you can see after, this is at baseline, and this is at 10 weeks, and this is at week 5. You can see there's no blood flow inside the circumscribed red tracing. Halfway through the study, we get more blood flow. And in this patient at 10 weeks, it hadn't closed yet. And you can see all the blood flow that's within that wound now. So the dermograft, or the replacement skin, was pro-angiogenic. And I'm telling you this story because I want to give you some take-home messages of how important blood flow is in healing the wound. It's one of the biggest indicators of whether it's going to heal or not. So what we had learned in the laboratory, this is an assay that we did. This is a chip core-entoic membrane, which is kind of a cool assay. It's that membrane over top of the developing chicken. So you just open up a little window in the egg, and then you can drop your elements on top of that membrane. If they're angiogenic, then blood vessels are going to grow towards it. And that's exactly what happened with the dermograft. And this is the control mesh with no cells on it. And we didn't see the angiogenesis that we saw in dermograft with control. VEGF, vascular endothelial growth factor, the production almost doubles after 2 days. And so this was our mechanism of action in this commercial product. So it got some off-label usage, it got a lot of publicity. And the off-label usage would come in formats that had nothing to do with the foot, and it had nothing to do with diabetic foot ulcers because it was healing wounds. And if you heard the CBI talk Friday, you'll know that there's a very specific process you have to go through in order to get technology approved by the FDA. And you have to have certain label claims where you're allowed to use it, where you're not allowed to use it. And you can't off-label promote. So we weren't off-label promoting, but doctors thought this thing was amazing, and so they were using it in pretty aggressive train wreck type of cases. Now this next slide is pretty graphic. It's not a train wreck, but this was man versus chainsaw. Okay? So this gentleman was cutting wood, slipped, the chainsaw went across his face. He presented at UCLA Medical School, and they called and said they were going to be using the dermagraft. And so we couldn't promote that, but we didn't. They had it on the shelf, and we said, okay, let us know how it goes. And this is a year, oh no, this is after the surgery, sorry, after the surgery, right? Approximating it as best as possible. So they're trying to get first intention healing if they can. You with me? So this is right after the surgery. Looks pretty good. Dermagraft was used in addition to this to treat, and this is a year later, a year follow-up. So what I want to ask now is, in this situation, do you feel like the result was regeneration, or was it healing? So don't shout it out, just talk amongst yourselves. Regeneration, or was it just healing? Regeneration, okay.
Because
now,
some of his mustache grew back and
okay.
his skin's a little oily.
Some of his mustache grew back. Skin looks oily, like maybe there's sebum that's being released, which it should. That's functionality of the skin. Okay, anybody else have it? Remember this whole idea of like, because that's one opinion from Dr.
Austin.
Dr. Austin?
Yeah.
Or also?
Austin.
Austin, okay. I thought you said Dr. Awesome. I was like, okay, we'll go with it.
Call me that too.
Dr. Wonderful? Yeah. Okay, so Dr. Austin, anybody have a contradictory idea or opinion? Yes?
Maybe not complementary, but supplemental. There's scar formation, so that would also be repair.
Okay, so some scar formation thinks it's repair. Okay, so different opinion. And where do you think the scarring is? Where do you guys see the scarring? Maybe on the bridge of the nose? Okay? So, is there, in this whole process of regeneration versus healing, functionality versus no function, is it one and never the other? Are they mutually exclusive, or do you have them somewhat overlapping and it's a spectrum? Does that make sense? So I would say, pretty amazing outcome. I would definitely say there's evidence of, I would agree with both, and I'm not trying to be diplomatic, I'm just saying I would agree with both. I think both are correct answers. I definitely see evidence of regeneration, because you see all the things that was described with respect to hair follicle restoration. Looks like sebaceous glands are working. And then we also see some areas maybe where there was more aggressive wounding. Maybe the first intention approximation wasn't perfect, and we see more evidence of some fibrotic scarring. Okay, so it's a spectrum. I just want you to walk out of here understanding that it's not necessarily they're mutually exclusive. Okay? All right, that's all I have for you. Don't forget your post-quiz on Friday. Maybe I'll see some of you on Wednesday night in Klein at 6:30. Have a great week.